Hey, what's up everybody? Thanks for joining today. We're gonna be talking about breath sounds. Now, this is one of the absolute keys to assessment. And if you've been working clinically at all, you'll know that across all disciplines, everybody does them a little bit different. Today's video, I'm gonna show you how to assess breath sounds like a respiratory therapist. You ready? Let's go. One of the most objective things in the assessment is breath sounds. Today I want to break them down, try to make it somewhat easy so that you can assess your patients accurately and the same way each time. And that's really key. So have an accurate assessment and then make sure you go through your assessment the same way. You're listening for sounds, and like with anything else that we do in medicine, it's so important that you're listening for a change from the last assessment. Listen to a once-time snapshot of a patient really doesn't tell us much at all. We need to have the progressive assessments going on and to know, I did not hear that earlier, I hear it now. Or the respiratory therapist assessment said this last shift, I listen now and there's something totally different. So I'm gonna give you a little idea of what we do as respiratory therapists when we're going into a patient's room to assess their breath sounds and kind of their overall respiratory status. This is so really cool today. We have this simulator called SAM. This is a student auscultation mannequin. He actually outputs different breath sounds. Really cool. Use a laptop over here. Right now he's wheezing. I'm gonna show you what it looks like to come in and do a breath sounds assessment. First thing I do with a patient when I walk in the room, this is outside of breath sounds, but I like to, obviously I address them and I get a response. So you can tell a lot about the patient, how they're doing by the response, specifically to their breathing. Now, are they speaking in full sentences when they answer you? Or when they say hi, or you ask them a question of how they're feeling? That's the first thing to kind of gauge their shortness of breath. The next thing I do is I start from the top and I kind of look down and I kind of assess the sides of their neck. So I'm looking specifically for JVD, jugular vein distension. That's going to show you back pressure on the right side of the heart, and that it's a big indicator that you could be dumping fluid over into the lungs. So looking for JVD, if you've never seen it on patients before, obviously Sam here does not have it, but you'll see these large jugular veins. They'll be kind of engorged. It's nice to know some people just live in that state, but it's nice to know how large they were before, and maybe a week from now when this patient comes in, or if I get to go see this patient in their home, has that changed at all? So I look there. The next thing I look at is I look at their clavicles. So you can't always see their clavicles. In this case, we can, and I like to watch as they breathe when I'm talking to them, or when they know I'm not counting their respirations, how they're breathing, and I look at the excursion of their chest. So it's also a really nice thing when you get to the side of them and you can look at AP diameter. But from the front side, I like to look at how much these clavicles are moving when they're taking their breath in. So if that changes 4, 5, 6 hours from now, I'm going to know that they may not say that they're short of breath, but their body is acting like they're short of breath. So there's something internal going on. So looking at those clavicles, a lot of times they have a patient gown on, you can see those, and look at chest excursion. Okay, is that normal or abnormal for them, or has it changed from the last time? I mean, you could get real in-depth, you know, is one side than the other, but static chest on one side from a pneumo, whatever. I wouldn't get super involved with that because this is a standard breath sounds assessment. So then what I'll do is I'll start with listening to breath sounds. You gotta put the stethoscope directly on the skin. I mean, that's just the way it is. I know it's so much easier to do it over clothes and all that kind of stuff. You cannot get a good assessment, and you won't get a good assessment if you're not putting it directly on the skin. So I always like to stand off to the side. I'm left-handed, which I feel like is a bonus, but maybe not for you right-handers, but I stand on this side of the patient and listen to breath sounds. So listen in 5 different places on their back. Each one's associated with the lobes of their lungs. So I always assess across from one another first. So I don't just go down the right side, 1, 2, 3, and then 2 on the left side. Now don't do that. I go right upper, left upper, right middle, and then I listen to the lingula area. It just kind of completes it. So I listen to 6 actually. And then I go right lower, left lower. And so I can compare those one to another. That's really important when doing your assessment, because if you hear something different on a side, especially if the patient's sitting up like this, if I hear unilateral changes in breath sounds, I'm going to relate that to something. In most cases, I'm looking at 3 different things. That's what it is. I'm looking at wheezing, I'm looking at fluid, and I'm looking at mucus. Okay? That's what I listen for to keep it super simple. Wheezing, fluid, mucus. They all sound different. The breath sounds for those, I'll go over those real shortly on the board over here and talk about what they mean. But I'm listening inspiratory and expiratory for those different things, and I'll break those breath sounds down to what's actually going on behind the scene. So I'll listen, have them breathe in their nose, out their mouth, in their mouth, out their mouth. It doesn't matter, anything like that. If their nose is clogged, obviously I'm not jacking with that. Then I'll come to the front, and this is just breath sounds. I'm not doing heart tones in this one, but listen to the front. So I'd want it directly on the skin. It'd be nice if Sam had a gown. He's ripped. Okay, cool. So on this side, inspiratory, expiratory, straight across. Inspiratory, expiratory. And then I will go, since there's so much tissue and it gets kind of funky dealing with stuff up in the front, I'll actually drop down to almost here on the side and listen to the left lower lobe and the right lower lobe, and I'm confirming what I heard on the back side, because it just gives you another angle of those lobes. So if I heard crackles on the right lower posteriorly, I expect to hear them anteriorly also. It just kind of hones the assessment a little bit. So when I go to document that, I can say, was not on the left, but definitely on the right. So 5 parts across the back, 2 up here on the apices, and then I kind of go around the side to do hit the lower lobe from the anterior aspect for that. Next thing, which is kind of a little unknown thing, some therapists know about it, but I like listening to tracheal sounds. Specifically, tracheal sounds are super nice if you think somebody, and I hate to say people do this, but they're doing this thing. They're forcing this like wheeze, and hopefully most people don't do that. But I do like to listen over the trachea, and just have them breathe normal when listening over the trachea. You won't know much about tracheal sounds right off the bat, but if you listen to a lot of tracheas, you'll know what's normal and what's not normal. So I'll listen to the trachea, have them breathe normal. They probably think you're listening to carotids or something, but I'm not. I'm listening to the air flowing through there. And then also, it's kind of like a big megaphone for what's going on in the lungs. So you will get some resonance up to the trachea. So it also can confirm some things, especially in the upper lobes if you have some wheezing going on, what's kind of going on up there. So listen to the trachea, about 3 breaths, and then that's usually my assessment as far as breath sounds go. I feel like I've done a pretty good job listening to every aspect of that, and then ruling out things by listening over the trachea. Trachea is also really nice to listen for. If you're looking for stridor, you just extubated somebody or you suspect that they have some swelling up in that area, listen to the trachea. But the problem is, if you just listen to the trachea on those patients, you won't know what a normal trachea sounds like. So it's really key to listen. Put the tracheal sounds in your breath sounds assessment. So on everybody. And just make it part of your normal assessment. Hey, you know what? Patients will think you're even being more thorough. So everybody wants a clinician that's more thorough. Throw that tracheal sounds in there and listen to normal tracheas so you'll know when something is not right. You can catch that stridor earlier, possibly save somebody from re-intubated. So that's a real key. Anyway, that's kind of the initial breath sounds assessment for Sam here. let's go over the board and let me talk about some of the sounds that you'll hear. So I know y'all enjoy my drawing because I'm terrible at it. You know, I'm more clinical, I'm not artistic. So, but I'm gonna talk about those sounds a little bit. So the three main sounds I'm looking for fluid, I'm looking for mucus, and I'm looking for wheezing. Mainly because those three things are treated three different ways. So I want to get really involved in a bunch of other breath sounds, you know, and one of my, I hate to say this, a little bit of a pet peeve is coarse breath sounds because, yeah, but coarse could be a combination of a lot of different things, but it's not definitive. We want to make sure, and if you are tired of giving albuterol for fluid, be more definitive with your breath sounds, okay? That's kind of the goal of it. So let's be more definitive in what we're looking at as far as breath sounds. No, fluid kind of has two different things we're looking at as far as breath sounds. So something called crackles. So crackles are, and I'll kind of give a demonstration of this with Sam in a short second, but I always think of crackles as fluid. You can also have a little bit of, I'll just kind of do a wavy line towards mucus to make some crackles, but the main thing I look at with mucus, and it's not coarse, but I call it ronchi. So ronchi is mucus, right? That's just the way I put it. And I do a little funky thing with my assessment, but it does, I think it pays off when you are kind of describing what's going on with the patient. If I hear ronchi, and we'll show this in a second, this is a low-pitched wheeze, people will call it, but I just kind of think of it as like, you know, you have these airways, that's a really bad airway, but you got this big chunk of mucus here, and it's just kind of vibrating when the air goes by it. It's not wheezing, like the air squeezing through there. It's just kind of vibrating, so it's making a low-pitched sound. If it truly is ronchi, that means, and this is the way I assess it, I assess ronchi is mucus that moves. So I can make mucus move in somebody's airways, just have them cough. And if they have an effective cough, it will move. And the cool thing is if it moves just a little bit, like it shifts like over here, it's gonna make a different sound. So I will very commonly listen to breath sounds, hear ronchi, those low-pitched wheeze, maybe it's in an upper lobe, or maybe it's usually unilateral, it's not all over, which means it's probably some mucus in an area. Then I'll leave the stethoscope on it. I'll actually pull it out like this so I don't get absolutely blasted, but I'll leave the stethoscope on it and I'll say, can you take a big deep breath and cough? Stethoscope, same place. And then I'll put it back on and listen. If that tone changed, I call it 100% ronchi. So what that is, that's mucus that moves. So in my assessment and in my treatment plan, what am I going to look at? I'm going to look at flutter devices, vest devices, those type of things, because we need to help mobilize this mucus. Also, increase fluids, right? Because I'm not worried about the fluid in the airways. I want them to increase fluids so that their mucus is less tacky and is easier to get out. So ronchi, mucus that moves, if you remember nothing else from this. And then wheezing is kind of our classic one, but wheezing, you can have unilateral wheezing, but very commonly it's gonna be something that's bilateral. And with wheezing, I always like to know what part, I'm gonna draw a CO2 waveform here. So this is time, and this is the, I'm gonna totally make this up, breathing rate. All right, so this is the patient taking a breath in and then exhaling. So in and exhaling. So what part of the respiratory pattern do we hear wheezing? We need to say, you can't just say patient's wheezing. You need to say, is it inspiratory wheezing? Do I hear it here? That's bad news, right? Is it expiratory wheezing? Do I hear it here? Or is it end-expiratory wheezing where I hear it like right in this little area? Now, I kind of went backwards there in severity. So what you're going to initially hear is end-expiratory wheezing. And why are you going to hear that? So just real simple, what happens with their airways, as they get closer to the alveoli or farther down there, they get smaller. So the bronchospasm is going to close them off more. So when you go to exhale, you're dumping that air towards the end, and as your airways constantly expand and contract. So when you go to exhale and they start to contract and you hear wheezing right there at the end of expiration, that's going to say there's some bronchospasm. It may not be terrible right now, but it's because their airways have closed down to here, and now you can hear the bronchospasm. So, number one, end expiratory. The next worst one is all of expiratory. So, need to know is did it start as soon as they started exhaling, or did it start at the end of the exhalation? So, expiratory wheezing is the next one. So, when it goes from this area right here, so they take their breath in, when they go to exhale, you hear wheezing all the way through. That's going to show that it's a little bit worse. And then I and E wheezing, inspiratory and expiratory, that's going to be with that wheezing when they're coming in and when they're going out. That's a lot of bronchospasm going on all over the place, and they need to be treated for that. So that's number three. So inspiratory, expiratory, and expiratory. So if I give a breathing treatment, an albuterol treatment for I and E wheezes, it almost always follows this pattern. This is what you're looking for in your assessment. Is this working for them, or do we need to go a different path? So I and E wheezes, they're the worst right now. I'm going to give a breathing treatment that's going to go in and loosen up. So I and E wheezes should go back down the ladder. I should start to hear expiratory wheezes, and then at the end expiratory wheezes, which means it started opening things up enough that I wasn't getting them on inspiration, getting them a little bit on expiration, and then end expiration. So that's a normal progression for a breathing treatment to say that it's therapeutically working without bringing them in and doing a kind of different spirometry and whatnot. So looking at the end expiratory, and I and E wheezes, and then giving bronchodilators and listening to them go back the other direction as that kind of improves. Wheezing is an interesting one. You can also get some wheezing if they have foreign bodies. That will be a very unilateral wheeze, so something's stuck in there and it's kind of letting air get by it, and it will, let's say this is stuck in there, so as the airways flex up and down, it's going to change that sound. Not super common. You're going to find that on a chest x-ray, hopefully. So hopefully you won't be finding it with wheezing. But this is bronchospasm. You need to know the difference. Wheezing, mucus or rhonchi, and then fluid and crackles. So let's take wheezing off the board. I could probably do an entire lecture on wheezing, but that's an important one to know. Let's go to rhonchi next, and we talked about this a little bit. Low pitched. Usually I'm looking at mucus here, and I leave the stethoscope on. I ask him to cough. If it moves, I call it rhonchi. If it doesn't, I'm like, okay, what could it be? Could it be really thick mucus? But I try to see if it'll move and change a tone. So this is very low pitched, and that could be really anywhere in their airways. If you're looking specifically to mucus and a lot of mucus production, upper lobes are commonly pneumonia and aspiration pneumonia for upper lobes, but you could have pneumonia anywhere, but you could hear a little bit of rhonchi with that as it breaks up. But for a true pneumonia, like a new onset that's just kind of just totally jacking with the person, probably a reason they're going to be in the hospital, it's going to be crackles. So with crackles, it used to be called rails, R-A-L-E-S, old school, and then the old school EMS called them rawls, which I just think sounds real hillbilly, but I like it. So if I'm in the right company, I'll call them rawls, but technically they're called crackles. So the best way to think about crackles is you have, well, you've seen my sacs of grace before, but you have all these different alveoli, and then when air goes in, these expand. Well, what happens is if you get mucus or you get fluid or anything like that blocking these, and these collapse. So you have atelectasis. When you take your breath in, it will reopen them. And when they open, they go and they crack when they open. So they open up, and then they'll probably close down again, and then they'll open up, especially when they take a deep breath. And it sounds a lot like Velcro, and I'll show you that shortly on Sam. So they take their breath in, and those open up, and then that is a crackle. So you should hear crackles when end of inspiration. Technically, that's when you should hear them, right? So if you're hearing, so back to this waveform again, you should hear them right about here, right? When somebody's taking their breath in, they get it fully in, you shouldn't be hearing crackles all through this area down here on the expiration. It should be right here. That's gonna, so you look at the breathing pattern, you're watching their chest as you're assessing, and then go around the front and listen to the anterior aspects of those lower lobes, and look for crackles. Now, if you have bilateral crackles and they are gravity dependent, so I like to think about this. I want to differentiate between crackles for fluid and crackles for mucus, because you saw mucus kind of went towards the crackles way. So fluid is gravity dependent, all right? So if you have your patient and you should never do this and have your patient like laying on their side when you listen to their breath sounds. But like, let's say this is their right side's up and left side's down. If they're in this situation for a long period of time, you will probably, let's just do the old box lung action here. You'll probably hear crackles down in this area, okay? That's gravity dependent crackles. So they're laying on their left side and you listen all the way up the left side and you hear tons of crackles, and you listen to the right side and you're like, there's no crackles. Fluid, 100%. It's unilateral, right? But it's gravity dependent. The patient is laying down like this. So it's another nice thing. Let's say you come back in 6 hours or whatever it be, they're laying on the other side and you hear it across the right lower side. That's why it's really important when you're listening to breath sounds to get them to sit up. Because what will happen is if they're sitting up, I want to make this guy stand up, gravity dependent will be the bottom. So you should, and it will take a few minutes for them to kind of shift, but that fluid actually shifts and you'll hear it more bilateral lower lobe crackles. When you hear bilateral lower lobe crackles, you're thinking almost always fluid. So when you're giving your assessment, you're listening to your crackles, you're saying, okay, is this mucus or fluid? Well, is it gravity dependent? Okay, so what side's it on? If they're laying like this and you hear crackles up here and no crackles down here on the left side that's down, that's a pneumonia, baby, right? So that's a crackle up here, and if they're not oxygenating well, you need to, actually they will oxygenate well because you got the good lung down, but we can talk about that another day. But if you hear crackles up here on this side and they're laying on this side, that's pneumonia, because the fluid would be down gravity dependent. So it's a great way to differentiate with your patients as far as if it's mucus or fluid by where the crackles are. So that's one of the things I like to do when I listen to that. Make sure you're looking at what part of the inspiratory expiratory cycle they are when you're listening to crackles. Now let's go listen to some of these on Sam. So the sound might be a little bit different now because I put the mic down here by the output, the audio output, just so that you can listen a little bit to what you may hear inside the patient. So I hope you can hear that. That's on end expiratory wheezing right now. And what you're going to see is that there's a waveform going on over here on Sam. And this small little blip, that's inspiration, and there's expiration. So you're going to see that long expiration. And let's see if we can hear the breath sounds with the mic. Now let's go in to listen to crackles. And I think you need to know what crackles sound like because they commonly get mischaracterized. But let's just go with medium. So they have fine, medium, and very coarse. So very coarse, you're kind of leaning towards, it's probably more like a mucus thing, mucus fluid mix. But this is medium, and I think this is a good assessment for where you would hear them on the patient. See at the beginning of inspiration, hear that popping, and then exhale. Exhale's normal. Cracking there at the end of inspiration, that's definitely crackles. Remember, fluid or mucus, if it's not gravity dependent, you could also have them cough and see if those crackles change tone. If it's mucus, they will a little bit. If it's fluid, they won't. Adding the cough in there is a little pro tip. Let's go into the next one. This one's called severe asthma. And so likely going to be in I and E wheezes. So you hear even a disturbance of flow as that's going in. Inspiratory there. And then the wheezes on the expiratory. So that's I and E wheezes, severe asthma. So that's something that you can definitely assess. This is his right upper lobe we're listening to. All right. right? And then they're calling this a low-pitched wheeze, but and so it is lower pitched. It does sound like a wheeze. If you hear something like this, it's not a tightness, it's kind of a lower sound. Hear something like this. This is when I'm going to leave the head stethoscope on them, pull it out of my ears, ask them to take a big breath in and cough, and then breathe normal, and then I'll listen after the cough to see if that tone had changed. If it does, I'll know it's ronchi or mucus. So treat it differently, you know, with our flutter devices, increased fluids, maybe a mucolytic of some type, clofenicin, something to cause more fluid in the mucus to get it out. But that's something you want to assess, and then also maybe a vest. So with those type of things. So if that tone moves, it's mucus. Hey, thanks for watching, everybody. Make sure you go below, check out my website. Also, I've got some of my RT Clinic badge buddies. I think I sold about 150 of those last year. Actually, probably sold twice that, 300 of them last year. And it looks specifically at oxygenation and ventilation. So check that on the website. Also, this has kind of been a little step into assessment from an RT's perspective on breath sounds. I could get a little deeper. There's some other funky deep stuff that you can get into. If you're interested in that, I could do some videos on that using Sam, because we can do some whispering pectriloquy and other things with this so that you can have an idea of what those are in case you see them documented, which you probably won't, but that's okay. It's nice to know that stuff, especially to do a good breath sounds assessment. So from Sam and Jimmy at the RT Clinic, thanks for watching, and I'll see you later.